Hey, welcome back. This video will be on things to consider for those with injuries when choosing shoes. As always, a reminder, you can find the written version of this video in my lesson under the Peaks formula on my website, peaksrunning.co. All right, let's get started. So on my website, you'll notice that this is listed in bullet point fashion, which may be a little bit easier to read than usual, but I go through a list of features to look for in shoes for a number of different foot-related pathologies. Starting out with hallux rigidus, which is first MPJ or your big toe joint arthritis. For this, usually you'd want a shoe with more of a rigid forefoot and rear foot rocker. Increased stiffness will limit unnecessary flexion throughout the big toe joint, and a rear foot rocker will promote heel to toe propulsion with less effort. Classic example of this usually is most Hoka models that people refer to, or I'm a big fan of Ultra. The Ultra Experience Flow has a good rear foot rocker as well. Bunions is a common one. For bunions, of course, if you can find a shoe with a wide toe box to prevent pain, that is usually caused by rubbing irritation on the upper. A soft mesh upper should help alleviate this. Some can also develop a tailor's bunion on the opposite side of their foot or corns on their fifth toe. They will equally benefit from a wider toe box for the same reasons. Again, the common classic examples for wide toe box, the two major brands that really market themselves in this way on the market currently are Topo Athletic or Ultra running shoe models. Neuroma pain, this refers to nerve pain between the toes or the distal metatarsals. People will usually get neuromas from a history of wearing shoes or cleats with a narrow toe box, in addition to often having less foot strength or stability, which is, again, worsened by wearing narrow shoes. These patients will also need a shoe with a wider toe box, though they'll also need further ancillary treatments, in my experience, due to how long it will take for that irritated nerve to calm down. Fourth condition here is Haglund's deformity. This is a posterior heel spur that is just anterior to the Achilles tendon. Adults will get irritation from the posterior bony prominence, which is known again as the Haglund's deformity. So they will need a less firm heel counter and something more flexible or forgiving. Those that experience a lot of irritation with this will probably want to benefit from a supportive recovery sandal often to wear around the house, which is better than the alternative that they'll turn to, which is just walking barefoot. Being barefoot will put increased stretch on their Achilles, which will probably make it feel worse. The next one is Achilles tendonitis, mid-substance, which means the middle of the tendon basically, and then calcanea apophysitis or what's known as Seaver's disease in kids. Kids will experience pain in their heels while their growth plate is still open at the location where the Achilles tendon is inserting, usually between the ages of 8 to 14. The following is usually overuse related and improves with RICE therapy, rest, ice compression, elevation, and offloading at the heel. The treatment for Achilles tendonitis is very similar, though the condition is, of course, affecting the tendon itself. Staying away from zero drop shoes is the number one priority for both of these injuries, and they're one of the only cases that encourage a shoe with a larger heel to toe drop. If somebody elects to stay with a lower heel to toe drop, they can augment it with a heel lift just placed under their heel inside their shoe. Next condition is posterior tibial tendonitis or PTT. This, in my opinion, is the primary one of the only few indications for a motion control shoe. Classic examples of these would be the Brooks Addiction or Brooks Beast. The guide rail technology that many motion control shoes now have, a straight last on the outside of their shoe and a firm heel counter will combine to attempt to isolate the excessive pronation of the foot, which will usually exacerbate symptoms in those with posterior tibial tendonitis. Peroneal tendonitis next. And this is in some ways the opposite of PTT tendonitis, and and is an injury that you do not want motion control or other rigid supportive shoes for. With peroneal tendonitis, we want more pronation since the injury is likely to be exacerbated by increased supination, which is inward rolling forces of the foot. So if possible, to find a shoe with more of a curve last, this will usually suit them best. A Hoka Clifton is a classic model for this, or the new Brooks Glycerin Flex has a really nice curve last. Otherwise, people with peroneal tendonitis often will do just fine with a cushion neutral shoe with a more firm heel counter. They have a high arch or a history of rolling their ankle. Next condition is gastrocsoleus equinus, and equinus is a fancy medical term referring to having tight calf muscles. This can be caused by a number of reasons, including inactivity, lack of stretching, prolonged history of wearing shoes with a high heel to toe drop, diabetes, and more. If when stretching your calves from a seated position, you are unable to create at least a 90-degree angle, thinking like this would be 90 degrees, but if this was a foot, if you can't do this, between your foot and your leg, when bringing your toes towards you, you have to be mindful of the heel to toe drop when purchasing a new pair of shoes. If you are historically used to always wearing shoes with a 10 millimeter drop or something large like that, and suddenly decide to wear minimalist shoes with a 0 drop, which refers to no drop from the heel to the toes of the shoe, you'll likely be placing excessive strain and stretch on the calf muscle complex, and this will increase the risk of it being strained or torn in some way. Some people can slowly convert to a lower heel to toe drop over time, provided that the conversion is gradual and accompanied by frequent daily stretching. Some people, such as those with progressive diabetes, will have tendons that are less forgiving. If you fall in this camp and are unsure if a certain pair of shoes is right for you, then you can consult with me or another medical provider before making the switch. All right, 2 last ones. Metatarsalgia. This refers to pain under the quote-unquote balls of your feet. Metatarsalgia, or pressure points in the forefoot on the bottom of your feet, occur for a number of reasons, but the 2 most common camps I see people struggling with it are older folk with fat pad atrophy, which is exactly what it sounds, and occurs naturally with the age in the forefoot and the heel of the foot. The second case is biomechanical in nature, I would say, occurring in all ages and due to poor walking or running mechanics or strength and stability deficits. Assuming the biomechanics are perfectly normal, then a shoe with a lower heel to toe drop in somebody with good calf flexibility is fine. One that is neutral, well cushioned in the forefoot, and having a rear foot rocker should all help take pressure off of the bottom forefoot of their feet. Last but not least is plantar fasciitis, and I left the most controversial one for last. You will see headlines for the best shoe for plantar fasciitis splattered all over the internet. Most of the features that all the running shoes that are advertised have in common are increased cushion within the midsole and especially within the arch. Aside from this, you can see a wide variety of shoes, including those with or without rocker, rear foot rocker designs, dress shoes, and shoes with anywhere from 0 to 16 millimeters in drop from heel to toe. So how do I know which shoe is actually the one? I have no idea. The internet rage and advertising campaigns that have benefited from this injury are not surprising, considering how painful and difficult it is to get rid of it for those that are afflicted by plantar fasciitis. You see this in any podiatry office all across the country, many patients per day. In reality, the shoes are only one factor at play that will help alleviate this condition, but here are some things to consider if you are currently plagued by it. So first, as mentioned, how much heel drop? As I noted, there is little to no consistency when it comes to websites recommending shoes for plantar fasciitis if the shoe should have a large or smaller heel to toe drop. This has always puzzled me since calf stretching has always been one of the primary treatment options that providers recommend for plantar fasciitis. I emphasize stretching less than most, but if you do believe that it's important and the patient is stretching 15 minutes per day while wearing a shoe with a 10 millimeter drop for 8 hours a day, how effective is that stretching going to be, is what I wonder. the shoe that they're wearing is automatically putting them back into a quote-unquote less stretched position. Referring back to my section on gastrosoleus equinus, counter-arguments to this point would be that shoes with a minimal heel-to-toe drop and a person with a very tight calf muscles can put them at risk of a strain or tear of their calf or Achilles, which I of course agree with. Because I think tight calves do have some effect on causing plantar fasciitis, I will try to steer younger people with better calf flexibility towards smaller heel drop shoes. With those for whom I think this would be too risky, I would prefer to focus on intrinsic support and function. Next question would be, what can be addressed with shoes alone? The most commonly documented causes of plantar fasciitis include overuse of the plantar fascia, increased strain on it, tight calf muscles, obesity, foot structure, and biomechanics. Features in a good running shoe that would most likely address a number of these causes would be increased cushioning, arch support plus or minus a custom or over-the-counter orthotic, and a lower heel-to-toe drop in a younger, more flexible patient. Older patients with less calf flexibility would benefit more so from a rocker bottom rear foot to help them propulse off. Research supports the idea that patients tend to get improvement in their plantar fasciitis symptoms with a thicker, more cushioned midsole in their shoe. In this patient base that is symptomatic, they are more likely to benefit from more cushioned and supportive shoes than a younger adult with feet on the flatter side that are otherwise asymptomatic. The last question is, so what are other providers missing? This is just my opinion. My belief is that one of the primary reasons that patients get plantar fasciitis as a result of overuse or increased strain on the ligament structure is due to improper functioning of the plantar fascia as a result of biomechanics. I'll see many patients in clinic with plantar fasciitis with perfectly normal arch heights and more calf flexibility than you and I combined. For these patients, is the treatment option simply more arch support and calf stretching? There has to be more involved, in my opinion. The function of the plantar fascia include aiding in shock absorption, supporting the medial arch of the foot on the bottom. Supporting the medial arch on the bottom of your foot, and aiding in propulsion off the big toe via what is known as the windlass mechanism. If the involved limb is more externally rotated at the hip as it should be, the individual is wearing orthotics or too stiff of shoes that prevent adequate flexion of the big toe joint, or any other biomechanical factors are at play that prevent the plantar fascia from functioning and pulling in the orientation that it is intended to, then the patient will experience increased strain and overuse of the ligament over time, no matter the flexibility of their calves or how comfortable their shoes are. This reinforces the importance of individualized evaluations of strength, mobility, and gait patterns up and down the kinetic chain when trying to treat the root cause of any injury, let alone plantar fasciitis. That is all I got for this lesson. Hope it was helpful. Thank you.